right, so welcome to the MPA MIA Melanoma Community Webinar Series. Tonight's webinar will be focused on Melanoma in Situ Explained, a patient's guide to living well. My name is Emma Gaynor and I'm the National Support Manager at Melanoma Patients Australia. This webinar is also proudly run in collaboration with Melanoma Institute Australia. MAA is a not-for-profit organisation dedicated to preventing and curing melanoma through innovative, world-class research, treatment and education programs. Melanoma Patients Australia is an independent, not-for-profit charitable organisation dedicated to providing vital representation and supportive care services to ensure no Australian affected by melanoma walks alone. Before we start this evening, we'd like to acknowledge the country we're on and pay our respects to our traditional custodians of the lands and their elders, both past, present, and acknowledge the deep continuing connection of Aboriginal and Torres Strait Islander peoples to the lands, waters, and skies. So tonight's webinar is our final instalment of our three-part webinar series brought to you by MPA and MIA. Our first was on sun protection after melanoma, and our second was understanding the role of the gut microbiome in immunotherapy treatment for melanoma. They are both available online currently in both of our websites. And our final webinar this evening will be on melanoma in situ and living well. So before we go on, I would like to take the option to the introduction of our great three presenters that we have this evening. We have Associate Professor Linda Martin, Claire Gore, and Jayde Feilo. Our first speaker of the evening is Associate Professor Linda Martin. Linda Martin is a Director of Dermatology Services at MIA and a Staff Specialist Paediatric Dermatologist at Sydney Children's Hospital. She's also an Associate Professor of Dermatology at the University of New South Wales. Linda graduated in medicine from the University of New South Wales in 2003. She undertook her dermatology training in Sydney and completed her fellowship at St John's Institute for Disease of Skin in London. Linda is interested in the early diagnosis of melanoma in high-risk individuals and skincare while on targeted and immunotherapy for metastatic melanoma. Her research focuses on moles and melanoma in pregnancy. So, if you can all give her a warm welcome. Linda, welcome this evening, and we look forward to hearing your presentation.
Good evening, everybody. Just checking you can hear and see me. Thank you for the opportunity to present about melanoma in situ, which I think is a topic which I think is often poorly understood, and I certainly think, I thank the hosts for inviting me to talk about this evening. So my talk I'm dividing into three main sections. What is melanoma in situ, or MIS, we often abbreviate it to? What does it mean for you when you get this diagnosis? And then what can you do about it as a patient? So starting off, what is melanoma in situ? And this is a complicated diagram, which you don't really need to understand, but it's to show that the skin is made of several layers. The very outside layer is called the epidermis, which is like a brick wall of keratinocytes, and that's really what makes you waterproof. Under that is a basement membrane, which is a thick layer of connective tissue. And then the next layer of the skin is the dermis, which is where the collagen and the blood vessels are. And then underneath that is some subcutaneous fat. Melanocytes live at the bottom of the epidermis, like these single cells you see here. And melanoma in situ is a proliferation or a growth of melanocytes, which stays in this very, very top layer of the skin. Invasive melanoma is when that melanoma then breaks through this basement membrane and spreads down into the tissues of the skin beneath and possibly beyond. So melanoma in situ is the most superficial type of melanoma, which is confined entirely to the very outside layer of the skin and protected from the rest of your body by the basement membrane of the skin. So the staging is also very complicated, and I don't know if you've seen these kind of tables with very complex staging, But the most important thing that I want to say this evening is that melanoma in situ is stage 0. So that is the earliest stage, and in some context is considered a pre-cancer rather than a true cancer itself. So the staging, melanoma in situ is stage 0. We have stages 1 and 2, which are localized invasive. So they're melanomas which are still in the skin, but have gone beyond that basement membrane. And then stages 3 and 4 are the metastatic ones where the melanoma has spread either to the lymph nodes or other parts of the body. And those are the ones which are associated with a much worse prognosis. Melanoma in situ, the prognosis is excellent. So what does melanoma in situ look like? Well, there are many different variants, and it can be some of which are very classical and some of which it can be a bit tricky. And they're divided according to the clinical subtypes, but also the histological subtypes. So that's what the pathologist sees when they look down a microscope. And again, that can be a little bit esoteric for you as a consumer to understand. But I'm going to go through some of the photographs of the common appearances here. So this is a typical appearance of a melanoma in situ of superficial spreading type. We can see it's an asymmetrical lesion. Yeah, it's got different colors of brown, and on the dermoscopy we have these asymmetrical peripheral dots, which is a big clue for us. Lentigo maligna is a subtype of melanoma in situ, which has a very distinctive histopathological appearance, but generally occurs on very, very sun-damaged skin. And when the skin is thinned and there are atypical melanocytes spreading along that basement membrane. And the dermoscopy can have different features. We have this, what's called an annular granular pattern around the hair follicles with asymmetrically pigmented follicular orifices of the hair follicle. And then we have acral lentiginous melanoma, which is melanoma of the nail apparatus, or melanoma of the sole of the foot or palm of the hand. Again, it has a distinct clinical appearance, and if it's melanoma in situ, the prognosis is excellent at these locations as well. Most melanomas are brown or pigmented. However, a proportion of melanomas can be amelanotic or pink, and in particularly in fair-skinned individuals. Generally, the fairer color your skin, the fairer your melanomas can be as well. And you can see that these lesions are much more clinically subtle and can easily be missed or biopsied because the medical practitioner thought it was a different type of skin cancer or a different type of rash rather than melanoma. So how common is melanoma in situ? Well, we don't only have data since 2002 because, as we discussed, melanoma is in situ is stage 0. It wasn't a reportable cancer to the Australian Cancer Registry until 2002, so we don't have data on the incidence before then. We do have in these graphs that the overall incidence of melanoma is increasing, which is largely due to this addition of melanoma in situ. But the reasons why the diagnosis is increasing are a little bit complicated. So it's partly because of increasing awareness amongst our population. People are seeking skin checks and are aware of the importance of having melanoma diagnosed early. We also have an improvement in the diagnostic techniques that we use clinically to diagnose melanoma. And importantly, there is also this concept of diagnostic drift or overdiagnosis, which you may have heard of, in which the classification thresholds for deciding if something is benign or malignant are slowly drifting towards being more and more cautious, which is good because we never want to miss a melanoma. But at the same time, perhaps in some cases, we're calling something a melanoma, whereas in the past we would have said it was a benign lesion. So what does having a diagnosis of melanoma in situ mean for you? Well, first of all, I'm going to talk about treatment, and then we'll talk about the prognosis. So, and there were some questions that came through earlier in the day, which I'll try to address. So the treatment guidelines are publicly available on the internet, and I've got the link for you here. In general, the treatment for melanoma in situ is the same as for localized cutaneous melanoma, and it's complete surgical excision with clear margins. You can see in some of this text that I've copied, there is a lack of evidence. There's not very strong evidence, but currently the recommendations are a 5 mm margin. And I want to just to make a special note that that 5 mm margin is a clinical margin, and when you cut out skin and then put it in the liquid to be sent to the laboratory for processing to look under the microscope, that specimen does shrink. So if your pathology report says there's a 3 mm margin, that doesn't mean you need to have further excision. It doesn't mean the doctor was wrong. It's just normal shrinkage. However, there are many situations, so most of the time melanoma in situ is easily treated, wide local excision, which reduces the risk of local recurrence, and that's all that's required. There are some special situations when we would include other treatments, and I haven't gone into these in a lot of detail due to the time constraints, but in particular for lentigo maligna on the face, when you have a large lesion, lentigo maligna in particular is prone to have skip lesions and a higher rate of local recurrence. We sometimes will use a field treatment with a type of topical immunotherapy called imiquimod, or in other situations, radiotherapy. That's particularly when we want to avoid extensive and disfiguring surgeries for lesions which are of long-term, very low risk of metastasis, but high risk of disfigurement if that's treated surgically. And there are definitely situations when we won't treat a melanoma in situ. We'll just observe it or we'll remove it, but we won't do a wide local excision. And that would be, for example, in the extreme elderly. For example, I had a colleague contact me about her 94-year-old grandfather recently, and it is completely reasonable, given the excellent prognosis of this tumor in some situations, to monitor it clinically. And with that, we use our eyes, we use a dermatoscope, and we can use other technologies to assess for local recurrence. In terms of the prognosis, and I think this is the main point of the discussion I wanted to make tonight, and the prognosis of melanoma in situ or stage 0 melanoma is excellent. There's a risk of local recurrence, which is the tumor coming back near the scar. That is rare, particularly if you've had a appropriate wide local excision, which occurs in by far the majority of cases. The risk of disease progression, that is the melanoma breaking off and spreading inside you to other parts of your body, is almost impossible. So really the main thing that we need to worry about for melanoma in situ is just the risk of subsequent primary melanoma, which is fairly common. It's about 10%. And the long-term outcome nonetheless is excellent. So local recurrence is when the tumor comes back in the scar. And I've got a picture here which is not particularly obvious, but that's not to scare you. It's just to show you what kind of thing to look out for. So first of all, coming back in the scar is extremely rare, and it would be more common in subtypes of melanoma like lentigo maligna. It's normally obvious. This one isn't particularly obvious, but normally if you had some pigment growing back in your scar, you would know, and you would know to see your doctor. So there's not something that you need to worry about or you need to have skin checks for. It's something you can just keep an eye on for yourself. And in general, if we do get a recurrent melanoma in situ in a scar, it's easy to treat. We can do a little bit more surgery, and generally that will be cured. In terms of the metastasis, will this break off and spread inside you? Really, that's virtually impossible. And so I think you can be very reassured that the diagnosis of melanoma in situ is a warning shot, but it's really not a risk to your health. The risk of subsequent primary melanoma, in contrast, is fairly high. You can calculate your own risk of subsequent primary melanoma on our website, the melanoma risk website. You go to the subsequent primary. On average, patients who have had one melanoma, whether it's invasive or in situ, their risk of a subsequent melanoma is about 10%. But if you've had two melanomas, then that risk increases quite substantially. So having multiple primary melanomas really is the biggest risk factor rather than, but one is not too bad. I wanted to draw your attention in particular to this publication in the JAMA Dermatology, the Journal of the American Medical Association from last year, which was a very large cohort study of 140,000 patients. And they demonstrated that patients with a diagnosis of melanoma in situ actually live longer than the general population. So this is excellent news, and it is perhaps explained by the fact that people who are having melanoma diagnosed in the stage 0 or in situ phase are generally healthy people who are seeking health screening, and they tend to do very well in the long term. I know I'm at time, but I'll skip through this section quickly if you're happy, moderators. So what can you do for your diagnosis of melanoma in situ? The most important thing is prevention. It's never too late to fall in love or to improve your sun protection, and there's very good evidence that sun protection works no matter how old you are and how many melanomas you have already had. In terms of screening for subsequent primary melanoma, this is a little bit trickier because the guidelines are lacking and the standard of care in the general population is a bit variable. Nonetheless, 1/3 of Australians undergo general skin checks. However, most melanomas are still identified by the patient before a doctor identifies them. So you still have a key role. We don't want people to obsessionally self-check because that can make you a bit anxious, but we do want you to know your skin, and if you notice something, then see your health professional. So how we diagnose things, most importantly, the patient having a lesion of concern, although you can't be your own doctor. Even I can't be my own doctor, but it is very difficult to distinguish between a benign wisdom spot and a melanoma in situ. But my key message is if you're not sure, you should seek help, because we would always prefer to see a benign lesion that you're worried about than to miss something that is potentially serious. We diagnose melanoma with naked eye examination, so looking for a lesion which is called an ugly duckling or something that stands out from the others. We use dermoscopy, which is a type of magnifying glass, and there are specific dermoscopic features which help us make the diagnosis. We use sequential dermoscopic imaging if we have a lesion which doesn't have specific features of melanoma, but stands out as being a bit different from the others. And if things change over a 3 or 6 month period, that's an indication for biopsy. And we use sequential total body photography, where we look at for new or changing lesions over a period of time. You can see this patient has very extensive moles, but the new melanoma was this tiny, tiny melanoma in situ, which you wouldn't diagnose without the photographs. Of note, as I said, life is not always easy, and not everything that changes is a melanoma. Moles themselves can be dynamic, and they mature and evolve as even slower than your brain, as I say to the teenage patients. So just because something's changing doesn't mean it's a melanoma, but it's definitely worth having a look at. And just to note that not all melanomas are obvious. So this pink nodule doesn't really have any specific features of melanoma, but it's a new lesion in someone who's got a high-risk phenotype. Other more advanced technologies which may not be as widely available are confocal microscopy. So this is doing a biopsy without cutting, and we can see the individual cells. And even without much training, you can see that there is quite a big difference between a melanoma and a mole and a wisdom spot. I might skip over the AI section, although we can take questions at the end. Just to say that at the moment, AI doesn't really exist. There's enormous potential. None of it is currently regulated by the TGA, and I would be very skeptical about any direct patient access AI apps or any doctor who's using AI on a regular basis. So what's the story with skin checks? And unfortunately, we don't have very clear guidelines, but we're certainly working on that. How often should you have a skin check? Well, that really depends on your level of risk of subsequent primary melanoma. In my practice, I tend to see people 3 months after they have a diagnosis of melanoma in situ, but that's normally an educational visit, because after the shock of the diagnosis, we touch base again after another 3 months to go over what this means for the future. And then I see people according to their risk of a subsequent primary. I think most of the time patients are able to assess the scar themselves for local recurrence. Where should you have your skin check? Well, I can't really answer that question other than to say you should see someone that you trust. Trust yourself and find someone that you trust, that you can have a long-term relationship with. And how, as I said, most of the time it's the clinical history of something's changing, clinical exam, dermoscopy, and the role of these more advanced technologies that I've shown you is still to be established on a kind of general scale. I do want to caution that unnecessary skin checks and unnecessary surgery doesn't prevent melanoma, so we do need to be judicious and make sure that we biopsy appropriately. We want to diagnose melanoma early when it's in situ and it's completely curable, but we don't want to harm people along the way. What about your family? You know, people are often quite worried about their family and what it means for their children. And all I can say is prevention, prevention, prevention is the most important thing. Your children do not necessarily need skin checks. In fact, they almost certainly do not need skin checks. They need to have proper sun protection to prevent melanoma in the first place. That might not be the reason why you have a melanoma, but this is what you should focus on with your family. And I would suggest people look up the WEBS tool for their family members to look at what the risk of a melanoma is in their family and use that to guide whether or not they should be having skin checks. Should you have gene studies? Well, again, this is complicated. The genetic testing is currently only available, publicly funded for CDKN2A, which is the most well-described gene, but certainly not the only one. And that's based on a compound score of your age at first primary melanoma, number of primary melanomas, number of family members, and pancreatic cancer. So this is not necessarily something which, so this is something which most people with melanoma will not be eligible for genetic testing. So my take-home messages are the most important thing is to know your risk, look after yourself, and most of all, buy yourself a hat because it might just save your life. Thank you very much, and I'll hand over to the next speaker.
Thank you very much, Associate Professor Linda. That was fantastic and very informative. I can see we're getting lots of questions coming through, so we'll be sure to dive into those once the next few speakers finish off. So our next speaker is Claire Gore. Claire is a psychologist with over 11 years experience working in the private and public health sector. She has a particular interest in the psychosocial impacts of cancer and is currently working as a psychologist at the MIA Clinical Psychology Service and for the Peter MacCallum Cancer Centre in Melbourne. Welcome, Claire.
Thank you very much, Emma. And thank you, Linda. That was an excellent presentation. Okay. So tonight I'm going to talk through some common emotional responses to a melanoma in situ diagnosis, as well as share some tips for looking after your physical health and emotional well-being after being diagnosed with melanoma in situ. And I thought it might be useful as well to share a strategy that patients that we see find helpful in managing some worries about melanoma. And I'll also talk through some of the support services available. So even though melanoma in situ is very low risk, receiving a diagnosis can still come as a shock, and levels of distress may still be high. We've got this quote here, when the doctor said you've got melanoma, bang, that sort of hit below the belt, and it was panic stations for a couple of days. I was totally freaked out, completely and utterly shocked. So it is normal to feel a range of emotions during this time, and also important to note that distress and anxiety are just as common in patients diagnosed with melanoma in situ as with other early stage melanomas as well. So friends and family may sense your distress and try to reassure you that it's all over, you don't need to worry anymore. We've got this other quote. I've had many people say, oh, you've just had a mole removed. And I'm like, it's actually cancer, believe it or not. So sometimes this might make you feel like others don't understand the fears that you might have or what it is like for you to have had a melanoma. So psychological distress can lead to lower quality of life, delay in seeking medical advice, and decreased adherence to post-treatment screening, such as attending and following through with skin checks. Also, people experiencing psychological distress are less likely to adhere to preventative behaviours such as sun protection, which may result in increased rates of recurrence. So we know that healthcare support is beneficial in reducing distress, so it's important to be aware of any changes in your psychological functioning. So how do we adjust to the diagnosis? We know that maintaining a healthy lifestyle is important for physical and emotional well-being during and after the treatment for your melanoma in situ. So maintain follow-up visits, keep up to date with follow-ups and skin checks, keep active. We know that regular physical activity is a great way to maintain your fitness, boost your mood, try to be active most days of the week, and when you feel ready, working up to about 30 minutes of aerobic activity 3 times a week. And you might like to add in some weight training or resistance exercise as well. So it is important to be mindful of any wounds that you might have if you've had a wide local excision and move within the recommendations of your treatment team. Eating a fresh, nutritionally balanced diet can help you maintain your energy, keep you feeling good, and about 6 cups of water a day are good to keep you hydrated. Also making time to rest and recuperate. Make sure you've scheduled downtime as well. So even though it is low risk, diagnosis can still be confronting. It might be helpful to stay well informed and prepared for what is to come. It's important to access information from reliable sources and remember that not everything on Google is fact-checked. Maybe write down some of your questions, talk them through with your treating team. Take control of your general health by making healthy choices to eat well, exercise, be sun smart. Maybe try some mindfulness or meditation to help quieten your mind. Try going to bed at the same time each night, avoiding screens and caffeine within an hour of bedtime to get a good sleep. You might find it helpful to write in a journal just to acknowledge and express the things that are causing some stress. It's important to be kind to yourself as well and allow yourself time to adjust to the diagnosis and any changes that you're going through. Maybe try talking about how you feel with people that you trust. You might like to reach out to some support groups and importantly, do things that you enjoy. If you're feeling overwhelmed or stressed, it can be helpful to have something to look forward to and making plans to do things that you enjoy. Even just going out for dinner or socializing with friends can help take your mind off things too. So if you have been diagnosed with a melanoma in situ, you might feel uncertain about your future or like you're not in control of your health. And you might also be worried that it will come back. And this is commonly called fear of recurrence. And worry postponement is one tool that can help contain some of these worries. So it is not about trying to get rid of thoughts or feelings. It's about noticing them in the moment and then returning to them later at a planned time and place when you feel like you're in a better headspace to deal with them. And it's important to acknowledge that some worry is helpful, helps us to motivates us to face things that we need to, but sometimes it starts to interfere with daily life and gets in the way of us living meaningfully and doing the things that we want to. So we've got 3 steps for worry postponement. The first one is to set a worry time. So choose a time that is convenient, that occurs regularly, ideally just before a natural transition, such as going to pick the kids up from school, as the shift in focus then makes it easier to unhook from some of the thoughts that you might be having, and avoid setting the worry time just before bed. Choose a place that's comfortable and free from distraction. It should not be somewhere that you go to regularly to relax, so don't do it in bed, and set a specific length of time, probably up to about 20 minutes. So step 1 is setting the worry time, choosing the time, choosing the place, and the length of time. And step 2 is to postpone your worries. So during the day, as you become aware of a worry or something popping into your mind, just jot it down, 2 to 3 words to jog your memory later. And remind yourself that you've got that time set aside, at 3 o'clock or whenever it might be, to come back to it then, to problem solve, look, analyze the worry later. And then refocus on what's in front of you and carry on with what you're doing. And then step 3 is coming back to the worries at your pre-planned time. So when it is that time that you've got set aside, pull out the list of things that you've been jotting down and cross off anything that is no longer relevant. That'll leave you with a shorter list. And then don't feel pressure to solve all of those worries at the same time. Things can be transferred over to the next day, just like a to-do list. And when working through the worries on your list, it might be helpful to use some problem solving. So you might ask yourself, what is it that I'm sad or angry or worried about? Is there anything I can do about this? And is there anything I can do about this right now? And importantly, if there is nothing that can be done about that right now, you might ask yourself, well, what can I do to look after myself in the interim? How can I be kind to myself now? And for people who like apps, there are apps like Worry Time, which is developed by Reach Out. And then also I like the Worry Tree app. Right, so what supports are available? So you might be well aware of the Melanoma Patients Australia website, which has some information about melanoma and its diagnosis and treatment. They've got support services, including the Melanoma Nurse Telehealth Service, support groups, peer support, and the Wellness Hub, which has more information about support and assistance to improve your wellbeing as you live with melanoma. We at MIA have recently developed these patient resource fact sheets. You can download these from our melanoma website on the patient information section. At the moment, we've got tip sheets on scanxiety, looking after yourself, living well, and also caring for a loved one with melanoma. Our website also has a whole host of information specific for people with melanoma. We've got patient information webpage, which has patient guides. There's a new melanoma in situ guide that's out now as well. The melanoma questions and answers booklet, patient videos, patient information brochures, and our patient support website has different supportive care matters blogs and articles written by our clinical psychology team. We also have a self-care and support guide, providing tips for looking after yourself and your emotional well-being and where to access further support, and some patient support videos too. If you are experiencing significant distress or it's starting to interfere with everyday life, a psychology referral might be of use. The APS Find a Psychologist service is useful for searching for a psychologist in your area, or you can search by specific issues. So you can search for psychologists with experience and interest in cancer. And the GP is the first port of call too. So go and have a chat with the GP. They can arrange a referral for you too. Or you might find it helpful to speak with one of the counsellors available through the Cancer Council, and there's a handy directory there of the melanoma support services on our website too. Thank you.
Thank you very much, Claire. Appreciate the time to go through all those tips as well. So lots of great resources to link into after this session.
Thank you.
I'd like to now welcome our patient story of this evening. So we've got Jayde Feilo, who is an HR professional and lives in Brisbane with her husband and 3-year-old son. With her fair complexion, Jayde has always ensured that she went for regular skin checks, and in early 2023, Jayde made an appointment to have a mole on her back checked as it had changed colour and shape, and the biopsy came back as melanoma in situ. After having the margins excised, the pathology came back clear, and when Jayde went back for a 3-month checkup, the doctor found another suspicious mole on her back and took out the biopsy, and it too returned as a melanoma in situ. Jayde once again returned for her 3rd-month checkup and again was informed by the doctor that there was another suspicious mole. This time, however, the doctor went straight to excision, and it too came back as melanoma. Drawing in from her personal experience with melanoma in situ of the past 12 months, Jayde understands the need for clear and understandable information regarding melanoma in situ to be provided to patients to mitigate fear and understanding that patients have when it comes to searching the internet for answers. So welcome, Jayde. Thank you for taking the time to share your story this evening.
Thanks, Emma. So as Emma touched on, the last 12 months has been a really interesting time for me. If Emma, you could just go to the next slide, thanks. After my dad actually noticed a suspicious mole on my back, I went to a local skin clinic that specialised just in skin checks and had the biopsy done. And as you can see, it resulted in the pathology coming back and the excision having to be made, which is captured in this large circle on the screen. Now that was quite confronting. As you can see from my back, I have a number of scars, and I've previously had biopsies taken off both my shoulders. So the doctor that I saw who did this process was very clear with the information they provided. I understood exactly what was going on. So I guess the shock came, thanks Emma, when I went back 3 months later and saw to the same clinic but to a different doctor, and was told that I had another suspicious mole and needed another biopsy. And that too, as Emma said, came back as melanoma in situ. And so what I wanted to share with you tonight about this one is when I was called by the clinic that my pathology results had come back, I was told that I needed to see the doctor that day. So immediately, the mind races to worst case scenario. So I up and left work, drove across town to the clinic where I'd been having my skin checks, for the doctor to say, oh, well, we just need to book you in to remove the margins. It's similar to what you had last time. And I was in somewhat of shock, because I was like, so you're telling me it's exactly the same as the one I had 3 months ago? And he said, yeah. And I said, but I've just been told that I needed to see you today. I've left work, like you're telling me it's not that serious? And he's like, no, it's the same as the one that you had 3 months prior. So I guess that experience was really nerve rattling. It was a 40-minute drive from the other side of town. So as you can imagine, my mind's like going to worst case scenario. And so I guess also what I want to share with you is at this point, I wasn't aware of Melanoma Patients Australia or MIA, and I wish I had been, because I did exactly what Claire touched on before, and that I delved into Google. Thankfully, it was only whilst waiting for my appointment in the waiting room, so I didn't get too far down that rabbit hole. But what I'm aware of now in terms of the services that MPA provides, like the telehealth nurse, I definitely highly recommend that people utilise this service for any questions or queries that they may have. I also think it's really important, as Associate Professor touched on, that you find a doctor that you can trust. Thanks, Emma. As you'll see, I then had the third, I went back 3 months after the second one, and they found another suspicious mole, did the biopsy, same thing again, melanoma in situ. And so by this point, over the course of 9 months, I was like, how many more of these are there? As you can see on my back, I've got a lot of moles. So I actually sort of second opinion. I thought where I was going was a reputable skin clinic, but took it upon myself to get a referral from my GP and go and see a dermatologist, just for that peace of mind, to get that assurance that this wasn't something, that a cycle that I was going to be stuck in every 3 months. And I'm really happy to say that I had my last 3-month checkup last month, and that's was all good. So I'm heading back in 3 months' time in September, and hopefully they'll continue to be all good. So yeah, from my experience, I guess what I would like to share with everybody that's on this call this evening is please utilise services like MPA and MIA they've got a lot of good, reputable resources, unlike Google. And again, as both speakers tonight have touched on, be sun smart. It's so important. And even though you may have experiences that make you feel uncomfortable, like mine had or did, continue to get the regular checkups. And if you really aren't happy, I highly recommend getting a second opinion, because going and seeing that dermatologist really allayed a lot of the fears that I had in terms of what was going on with my my experience. So yeah, thank you.
Thank you very much, Jayde. I appreciate your honesty there. It is a hard topic to express everything in the open forum, so thank you for taking the time. So we're now going to our question and answers for the evening. So I'll get all of our speakers to turn their videos back on and their mics. Thanks, guys. Fantastic. And we've got a fair few questions coming through. A lot of them, as you can imagine, are for you, Linda, but there are a few that go around as well. One thing that keeps coming up, I can see, is, you know, we talk about melanoma in situ being pre-cancer. So if that's the case, why do we need wide local incision as the intervention for treatment in that respect? What's the reasoning behind that?
Look, it's a very good question. And as I alluded to in the slides when I copied some of the information from the guidelines, really we do not have very good data on that. You know, the wide local excision is based on historical consensus. And in general, in melanoma, I don't want to say anything too controversial on this setting. In general, in melanoma, margins are getting small. You know, I think in the 50s, people had this idea that you could, if you took out this huge chunk of skin, then somehow you would magically save a patient. And people did massive excisions. And as time goes by, the recommended wide local excision margins are getting smaller and smaller. If you think about other cancers, breast cancer, bowel cancer, we don't do a wide local excision. We want a clear margin, but we don't do an extra bit. So why do we do a wide local excision? It is really to reduce the risk of local recurrence. And it is because in many cases, and particularly for certain subtypes of melanoma, it's very difficult to determine histologically where that melanoma stops and where the normal skin starts, because you normally have a melanocyte is scattered generally every 6 cells in that basement membrane. You'll have 6 keratinocytes, one melanocyte, another 6 keratinocytes. And in someone with very sun-damaged skin, which is many of us in Australia, it can be difficult to be very confident where the melanoma stops and the normal skin starts. So the wide local excision is a precaution to prevent local recurrence. Does it need to be done? Look, I think if you have there are certainly situations when we decide not to, but I wouldn't decide it yourself. You know, if we're going to deviate from practice guidelines, we would normally take it to a multidisciplinary meeting and have a consensus discussion amongst a surgeon, a dermatologist, and a pathologist that not doing a wide local excision is in the patient's best interest. And that would be in situations when cosmetically it would be very disfiguring, or as I said, in the extreme elderly, when really you'll be submitting somebody to invasive surgery with very little chance of that being of a long-term benefit. Did I answer that question? No, but it's complicated.
Yes, I understand. And I guess something very similar to that, someone was asking about when you get follow-up or subsequent melanomas following the first in situ, is it typically that they're close to that first one, or there's no real correlation there as such?
No, they don't tend to cluster on the body. So having had one melanoma in situ, as I said, the real risk is that you will get another one. Once you've had one, your chance of getting another one is higher than if you haven't had one. But it doesn't tend to cluster on particular body parts. So you could get the next one anywhere. Actually, I noticed in the chat there are quite a lot of questions about subsequent primary melanomas. So maybe we can address them all at once. If you have had one primary melanoma, on average, your risk of a subsequent primary is 10% over the next 10 years. So that's like 1% per year. It's not high, but it's, it's recommended that you have a structured skin check program, as opposed to if you haven't had a melanoma, when, there are a lot of people having skin checks that probably don't need them. If you've had two primary melanomas, your risk of a subsequent primary becomes about 50%. And then once, Jayde, you've had three primary melanomas, then we start getting up to, 75 and beyond. So it's the number of primary melanomas that influences your risk of a subsequent primary. And will the next one be in situ or invasive? Well, we don't know. That depends on what it looks like and, how easy it is to diagnose. And what the growth kinetics of that tumor are. Some melanomas are very slow growing and some are very rapidly growing. So generally we aim to diagnose things as early as possible, but there are situations when it's not that easy. There was a question about subsequent primary in patients who've had a successful response to immunotherapy. No, immunotherapy doesn't seem to affect your chance of subsequent primary. So you can get a cure of your metastatic melanoma with immunotherapy, but it doesn't affect that underlying risk of subsequent primary, which we discussed already, about 10%. Does vitamin B3 decrease risk of B2 and B12? I don't know about those vitamins. I've never heard of that. B3 reduces the risk possibly of BCC if taken at very large doses, but it doesn't, there's no data that it improves risk of melanoma. In fact, in the trials, they had about 200 patients in the trial, and there were 2 patients who got melanoma in the B3 group and 3 patients that got melanoma in the, no, three in the B3 group and 2 in the placebo. So it was a slight increase, which is probably just random. But certainly we're not advocating vitamin supplementation for melanoma prevention. So,
okay. No, that's fine. And I know a lot of patients have called us, and there's been a bit of discussion around, particularly last year, and this came up in a question as well. There was thoughts around changing the name of melanoma in situ to not have melanoma anymore and be renamed because of that fear. Is there still talk of that? Do you know much about that, Linda?
there is still talk about that. Look, ultimately, I think that kind of decision will be made by pathologists. It's a pathological diagnosis and a pathological classification. It is true, I think, that the word melanoma, particularly in Australia, is very confronting. And yeah, we know that we tell people they have a melanoma in situ and all they hear is melanoma. And it takes a little bit of time to process it and then reframe it as actually not being that dangerous. That said, I think even if they change the name, yeah, it may reduce the anxiety. It's not going to change the risk of subsequent primary.
Yep. I might go to Claire now. We have a question, this comes up regularly, that someone had a melanoma in situ and they're still very paranoid. I know that you went through a couple of those strategies, but their biggest concern is always that their doctor misses something. Is there any advice that you think that they should take on to help with that in particular?
That is something that we hear commonly, and of course, if the doctor has missed something, it is very hard then for anybody to go back and trust that a subsequent melanoma will be picked up. And I think Linda and Jayde touched on how important it is to have a doctor that you trust. They're the best person to be doing the skin checks. And so it is okay to get a second opinion or to find another doctor that you feel comfortable with for those skin checks. We also have, I think it was last year, we did a webinar on managing fears of recurrence, because it's so common. It's the most common unmet ongoing need for anybody with any type of cancer diagnosis. That was in the last year's MPA MIA webinar series. So that might be a useful resource. I think as well, talking to your doctor or accessing some of those support resources that we've put up can help. to manage some of the distress.
And look, we agree. I think trustworthiness of diagnosis is really important, and it's also the key thing which is missing in the kind of skin check industry in Australia, and it's really what we're looking at, researching and tightening with the targeted melanoma screening. Is that we do need to know who should be screened, how often they should be screened, and how they should be screened, to make that diagnostic accuracy of the skin check more trustworthy. Because as I said, this is Cecilia, and it isn't always easy. You can have false positives, you can have false negatives. There is no the only test is a biopsy, and all of the other tests we're using are a clinical diagnostics age which triage you towards or away from taking a biopsy. And I really hear and I feel for people that you are right in being worried about that uncertainty, because it is uncertain. We don't always get it right. We try very hard, and there are ways to be more confident, but there is an intrinsic uncertainty in the diagnosis of melanoma, particularly clinically subtle types.
And we have patients calling all the time that they want to get as many tests and all types of checks and balances as they can to make sure. And a lot of it comes down to that total body photography that I can see is a bit of a discussion coming there. If someone wants to go on their own accord and get that screening and that testing, are there places that they can privately? How does someone access that total body photography?
And look, I'm going to answer your first comment first, in that, yes, you want to have more checks, but actually sometimes over checking will send you insane and make your anxiety worse. So it's a delicate balance of being proactive, advocating for yourself. Advocating for yourself in healthcare is really important, but it's often quite hard because you don't want to step on toes and you don't know, what's normal, whether you're right, whether your doctor's right. Like, I understand that it's hard, but so advocate for yourself, but don't overcheck and don't over seek checking, because that doesn't help. Total body photography, again, that's a watch this space. So there was an application made to the MSAC, which is the body which determines whether or not to have an item number with Medicare for something, for photography, melanoma surveillance photography, about 10 years ago, which was not successful because it's very, we need to define exactly what this mole photography will entail. The government doesn't want people taking dodgy photos with their iPhone and then billing the government, huge amounts of money for something that's just not really of benefit. So there is a major trial in progress, the IMAGE trial, which is a randomized controlled trial of melanoma of photography versus no photography for people with a recent diagnosis of melanoma. Those results will come out in the next year or two, and hopefully that will then create the evidence required for an item number, so it will be rebatable. Where do you go at the moment if you want to have total body photography? Look, I mean, I can only speak from my own experience, and about a third of the melanomas we diagnose are based on things which are changing on photography. And I think we could give advice in a state by state or city by city about where you might be able to access that service.
No worries. And what about like blood tests? Are they markers that you can pick up? I know a lot of patients ask about that as well. They're blood tests or anything like that, or is just like you've said, the eye and looking for changes? Is that the best bet?
There are no blood tests for melanoma.
Yeah.
No blood tests for melanoma in situ, no blood tests for metastatic melanoma.
Yeah.
I mean, again, that's something which people are doing research on, because wouldn't it be cool if there were a blood test? But currently there is nothing.
Yeah.
Well, there's nothing which is validated and recommended in the guidelines.
And Jayde, before we finish off, it'd be great to hear it's very current for you, and you're just going through this process and, coming up to, fingers crossed, and all clear coming up in the next month or so. How are you managing this situation, and around the fear of recurrence and things like that? Are there things that you're employing in your life that you're doing differently, or have you just managed to keep busy and get on with it? I know you've got a young son, and that would keep you busy as well.
Yeah, I think the biggest thing for me is not as I mentioned, not going down that rabbit hole, and having now found a doctor that I trust. So really not trying to worry about it, and knowing that, you know, I'm attending the 3 monthly checkups, and that's regular enough to pick up on something if it has changed. So I guess having had the last appointment where it was clear, I'm a lot more settled. I guess it's not taking up as much space in that worry space as what it was before, because I was really concerned. I was on this hamster wheel where every 3 months they were going to cut something else out. But yeah, like I said earlier, I think having a doctor that I trust, and, you know, doing my side of the thing by turning up, making sure I'm turning up for those 3 monthly checkups and not letting that time lapse, is the best thing that I can do. And then also knowing that if it is something that becomes of a concern, that there are resources from MPA or MIA now that I can draw upon, as opposed to resorting to a Google search. And like Claire touched on in her presentation, it's hard to talk. It seems to be stuff people don't feel comfortable talking about it, or you get the throwaway comments. So yeah, I think having reputable resources that you can draw information on when outside of your doctor, it's sort of hard to know who to speak to, is invaluable. So
yeah, thank you to our wonderful speakers tonight for giving up your time and to share your insights with us. A big thank you to all of you for being a part of this webinar this evening, and for the entire series that we've had. It's been a great 3 weeks. Just a friendly reminder to complete the survey that will pop up when you close this webinar this evening, and there will be a recording on both the MIA and MPA websites in the coming day. Thank you all again for listening. Take care and good evening all. Thank you.